You know, in the ICU, speed is, well, it's religion, basically.
Oh, absolutely.
Like, if a patient comes through the doors dying of severe sepsis, the golden rule of medicine is just to blast them with antibiotics instantly. You push the drugs fast, you spike the levels in the blood, and you just hope you kill the infection before it kills the patient.
Yeah, that's always been the reflex. Get it in them immediately.
Right. But what if I told you that the new gold standard for saving that person's life is to actually deliberately slow down?
It's wild. I mean, it completely flips the traditional critical care mindset totally on its head. We're essentially moving away from this strategy of rapid bombardment toward a strategy of a sustained siege.
And that paradigm shift is exactly what we are going to unpack for you today. We've got a really fascinating stack of sources to go through for this deep dive.
We really do. Some massive changes just dropped.
Yeah. We are looking at the brand new Surviving Sepsis Campaign, or SSC 2026 guidelines, plus some massive international randomized controlled trials and some cutting-edge meta-analyses that just, well, they fundamentally changed the rules of the game.
They did. The data is just undeniable at this point.
Exactly. So our mission for this deep dive is to give you a complete, up-to-date shortcut on why the standard of care for administering antibiotics in the ICU has been rewritten. Okay, let's unpack this. Let's jump right into the big update in these 2026 guidelines.
Right, so the core of the update is that the SSC 2026 guidelines now issue a formal, strong recommendation. And this is for the prolonged infusion of beta-lactam antibiotics for adults with sepsis or septic shock.
A strong recommendation. I want to pause on that word strong because, a few years ago, back in the 2021 version of these guidelines, this was only a weak recommendation.
Yeah, exactly. It was more of a suggestion back then.
Right. A weak recommendation basically leaves clinicians to their own devices. But now, the guidelines are planting a flag and calling this the gold standard.
And that shift didn't just, happen in a vacuum. It was driven by this massive accumulation of high-certainty evidence from huge trials over the last couple of years.
So they finally have the data to back it up.
They do. They've backed this up with moderate certainty evidence. But to really understand the data, we first need to make sure we're speaking the same language.
Good point.
Because prolonged infusion is kind of an umbrella term.
Yeah, so if I'm looking at a patient's chart or if I'm a nurse setting up an IV, does extended infusion just mean a slower drip than normal? Or is there a strict mathematical cutoff we're looking for here?
There is actually a very specific cutoff. So under that big umbrella of prolonged infusion, you basically have two distinct strategies.
Okay.
The first is an extended infusion. This means the antibiotic is infused over at least half of its total dosing interval.
Wait, half the interval? So what does that look like in practice?
So if the pharmacy says a drug needs to be given every 8 hours, an extended infusion means you're slowly dripping that single dose in over 3 to 4 hours.
Oh, wow. Instead of just pushing it all in over 20 or 30 minutes like a traditional bolus dose.
Yeah, exactly. That's a huge difference for the patient's body. And then the second strategy is a continuous infusion.
And I'm guessing that one is literal.
Totally literal. The antibiotic is hooked up to a pump and infused constantly without stopping over an entire 24-hour period.
So we are taking drugs that we used to basically just blast into the bloodstream, and we're stretching them out over hours or even entire days.
Which is a massive logistical change.
It is. Which brings me to the biological paradox here. Because when someone's blood pressure is just crashing from septic shock, their organs are actively failing.
Right. It's a terrifying scenario at the bedside.
So why is the new medical consensus telling us to pump the brakes on the delivery of the cure?
Well, to make sense of that, we have to look really closely at the mechanics of the drugs themselves. The pharmacokinetics and the pharmacodynamics.
PK/PD stuff.
Exactly. Beta-lactam antibiotics are what we classify as time-dependent bactericidal agents.
Time-dependent. So they don't necessarily care how high the absolute peak concentration gets in the blood. They just care about how long the drug actually sticks around in the system.
That is the crucial mechanism right there. To effectively kill bacteria, the concentration of the free active drug in the patient's blood needs to remain above a specific threshold.
And what's that threshold called?
In microbiology, we call this the minimum inhibitory concentration, or the MIC.
Okay, the MIC.
Right. So for beta-lactams to actually do their job, the drug levels must stay above that MIC threshold for at least 40% to 70% of the entire dosing interval.
And if it drops below that?
The moment the concentration drops below that line, the bacteria just stop dying. They literally start repairing themselves and multiplying again.
Oh, wow. So it's like boiling an egg.
Right.
Yeah, like turning the stove to 1,000 degrees for 30 seconds does literally nothing to the egg. They can't just blast it with heat.
Oh, I see what you mean.
You need a sustained, steady heat over time to actually get the job done. It's not about the maximum temperature, it's about the duration of exposure.
That is a perfect analogy. The 1,000 degrees gives you a massive immediate spike way above what the egg needs at that 1 second. But if it's gone just as quickly, it doesn't work. You need that steady, sustained exposure.
But wait, if we've been using the 1,000-degree method, the rapid bolus, for decades, it must keep the drug levels high enough for long enough in a normal person, right?
Well, yeah, in a generally healthy person who comes into a clinic with, say, a routine infection, the quick bolus method works fine. Their body processes the drug normally.
Right.
But sepsis is a state of physiological chaos.
Mm.
Sepsis wildly alters a patient's pharmacokinetics.
How so?
The systemic inflammation causes their blood vessels to become incredibly leaky. Fluid shifts out of the blood and into the surrounding tissues. We call it third spacing.
Oh, right. So the fluid literally leaks out of the veins.
Exactly. And on top of that, their kidney function becomes highly erratic.
So if you push that quick bolus of antibiotics into a septic patient, the leaky vessels and the erratic kidneys just flush it out of the usable bloodstream almost instantly.
It rapid drains, the drug concentration spikes, but then it rapidly falls to subtherapeutic, entirely ineffective levels.
So they drop below that MIC threshold way too fast.
Yep. The prolonged infusion acts as that steady heat, constantly replenishing the supply to prevent that dangerous dip. And actually, we should add some drug-specific nuance here.
Yeah, let's get into the specifics.
Because this prolonged strategy is incredibly beneficial for specific types of beta-lactams, namely the agents with very short half-lives.
Ah, okay. The sources mention drugs like piperacillin and tazobactam and the carbapenem class.
Yes. Because those specific drugs naturally clear out of the human body so incredibly fast, they benefit the absolute most from being constantly topped up by a slow drip.
That makes a lot of sense.
In fact, the Dutch guidelines actually make a very strict distinction on this front. They strongly recommend prolonged infusion, specifically for those short half-life agents, like piperacillin, tazobactam, and carbapenem, but give a much weaker recommendation for longer-acting drugs.
Because if a drug already hangs around in the bloodstream for a long time naturally, you don't really need the slow drip method to keep the levels up.
Right, exactly.
Okay, so the biological theory here is fascinating, and the mechanics totally make sense. But theory doesn't always translate into a statistical reduction in human deaths in a chaotic intensive care unit.
No, it definitely doesn't.
So what actually pushed the guideline committee to officially declare this the gold standard? What's the hard data?
The real turning point was a landmark meta-analysis published in JAMA in 2024 by Abdulaziz and his colleagues.
A JAMA paper, okay.
Yeah, and they didn't just rely on a single data set. They pulled 18 different randomized controlled trials.
18?
Yes, capturing over 9,100 patients.
Over 9,000 critically ill patients. I mean, in the ICU research world, that is a monumental sample size.
It gives the findings incredible weight. And the way they analyze the data is just as important. They used a Bayesian statistical framework.
Okay, Bayesian. Break that down for us.
Well, instead of just looking for a simple yes or no statistical cutoff, like a standard p-value, a Bayesian approach looks at all the data and asks, given all this evidence, what is the actual probability that this treatment works?
Oh, I see. It updates our beliefs based on the sheer volume of the incoming signals.
Exactly. And the signal here was deafening. They found a 99.1% posterior probability that prolonged infusions reduce 90-day mortality.
A 99.1% probability of reducing death. That is virtually a sure thing.
It really is. And when you translate that into clinical practice, it yields a number needed to treat an NNT of just 26.
Wow, just 26. So if you're an ICU nurse or physician listening to this, think about what that NNT actually means for your shift.
It's powerful.
It means that for every 26 times you hang that slower IV bag, instead of pushing the quick bolus, you are literally sending one extra patient home to their family who otherwise would have died of sepsis.
Yeah. In a disease where the mortality rate is notoriously stubborn, an NNT of 26 is just staggering. It's a massive clinical victory.
It is, but I do need to push back here for a second, because if you read through the source stack, there is a very large elephant in the room. regarding those 18 pooled trials.
Yes, the Bling-3 trial.
Exactly. The single largest trial in that JAMA meta-analysis was the Bling-3 trial. And Bling-3 had over 7,000 patients spanning 7 different countries.
It was a massive undertaking.
But Bling-3 actually failed to reach statistical significance on its primary endpoint of 90-day mortality. Its p-value was 0.08.
Right.
So if I'm a skeptic, I'm looking at this and asking, how on earth can the SSC guidelines issue a strong recommendation if the biggest, most expensive trial didn't technically hit its primary endpoint?
That is the exact tension that makes evaluating medical literature so complex, and it's why we really have to look past the headline binary of a p-value.
So 0.08 isn't a total failure.
Not at all. A p-value of 0.08 just means the trial missed the traditional, somewhat arbitrary 0.05 cutoff for declaring statistical significance on its own.
Right, it missed the finish line by a hair, but it doesn't mean the treatment was a failure.
Far from it. What's fascinating here is when you look under the hood of the Bling-3 results, there was a clear, absolute reduction in mortality of about 2 percentage points in the prolonged infusion group.
2% absolute reduction is still a lot of lives.
Exactly. And they also saw significantly higher clinical cure rates. The investigators themselves wrote in their conclusion that the confidence interval of their data included a clinically important benefit.
So it was trending heavily towards saving lives. It just lacked the singular statistical power to cross that 0.05 threshold in isolation.
Which is the entire purpose of a meta-analysis like the one by Abdulaziz. When you take that massive, very real signal of benefit from Bling-3 and you combine it with the data from the other 17 trials, the statistical noise cancels out.
I get it.
The true underlying effect, that mortality reduction, shines through with that 99.1% probability.
It's like looking at a single political poll where a candidate is winning, but it's within the margin of error, so you can't be totally certain.
Yes.
But if you aggregate 20 different polls that all show that exact same slight lead, you can be overwhelmingly confident that the lead is real.
That perfectly captures the Bayesian approach. And, there's an entirely separate layer to this data that makes prolonged infusion an absolute necessity.
What's that?
The rising threat of highly resistant organisms.
Oh, right, the superbugs.
Yes. We are dealing with pathogens like Pseudomonas or ESBL-producing Enterobacterales.
And those are incredibly hard to kill.
Very. To put it simply, these are gut bacteria that have acquired special enzymes that act like molecular scissors. They literally shred our standard beta-lactam antibiotics before they can even work.
Because they have those defenses, their minimum inhibitory concentration, that MIC threshold we talked about, is much higher, right?
Exactly. It takes a significantly higher concentration of the drug to actually overwhelm their defenses and kill them.
So how does the dosing strategy change things?
Well, for pathogens hovering right near that susceptibility breakpoint, a standard rapid bolus will almost always fail. The concentration might briefly spike above that high MIC line, but it will drop below it almost instantly.
Because the body's flushing it out.
Right. So in those scenarios, utilizing a prolonged infusion isn't just some clever biological optimization. It is quite literally the difference between the antibiotic functioning or the drug just vanishing from the blood before it can kill the superbug.
So the slow, steady drip is the only physical way to keep the concentration high enough for long enough to drown out the resistant bacteria.
The research completely backs that up, especially using Monte Carlo simulations.
Wait, what are those?
Essentially, researchers run tens of thousands of virtual mathematical patient profiles through a computer model. They want to see if a specific drug dose will successfully hit the required concentration targets.
And what did the computer models show?
Those simulations show that for highly resistant Klebsiella strains, prolonged infusions of piperacillin tazobactam are virtually the only way to achieve adequate target attainment. The standard bolus simply cannot maintain the siege.
Wow. Okay, so looking at the 99.1% probability of reduced mortality and the clear mathematical advantage against superbugs, an obvious question comes to mind.
Let's hear it.
If this is so undeniably effective, why isn't it trivially easy to just hook every single patient up to a continuous 24-hour drip the second they hit the ICU doors? What are the logistical roadblocks here?
The roadblocks are actually significant, starting with a massive safety warning highlighted in the 2026 guidelines. You cannot, under any circumstances, just start a slow drip right away.
Right. The loading dose. The guidelines are adamant that you have to start with the standard shot first.
It is an absolute necessity to prevent a fatal delay in treatment.
Why is that?
Think about your egg analogy again. If you only use a very low, slow heat from the start, it's going to take hours before the water is even warm enough to start cooking the egg.
Right.
If you just start a slow, continuous infusion of antibiotics on a septic patient, it could take 6 or 8 hours for the drug concentration in the blood to actually climb up and reach that crucial MIC threshold.
And in septic shock, every single hour you are below that threshold, the bacteria are multiplying exponentially and the patient's organs are literally dying.
Exactly. So the
Yeah.
protocol must be, you give a standard loading dose first, a quick, heavy bolus to immediately spike the concentration above the threshold, and then you seamlessly transition to the prolonged infusion to maintain that height.
So you turn the stove on high just to get the water boiling instantly, and then you turn it down to a simmer to keep it boiling, spike it, then sustain.
Spike it, then sustain it. Exactly. But even when you execute that perfectly, the physical environment of an intensive care unit presents major hurdles. Two of the biggest are drug stability and IV compatibility.
Oh, because the drugs go bad.
Yeah, right. Some of these complex antibiotics begin to degrade rapidly at room temperature once they're mixed in a saline bag. If a specific drug goes bad after 4 hours sitting at room temperature, you physically cannot run it as a 24-hour continuous infusion.
So the pharmacy would have to constantly mix and deliver fresh bags all day and night just to keep the single continuous line running.
It's incredibly labor-intensive. And then you have the issue of IV real estate.
IV real estate, like running out of lines.
Exactly. A critically ill septic patient is incredibly complex. They might have the drug norepinephrine running constantly in one IV line to force their blood pressure up, heavy sedatives running in another, and liquid nutrition in a third.
Wow, yeah.
A prolonged antibiotic infusion occupies a precious IV catheter line for several hours or even the entire day.
And you can't always just mix them together in the same plastic tubing to save space, right?
Definitely not. Many of these drugs are completely incompatible. If they mix in the same line, they can crystallize, form precipitates, or neutralize each other.
That sounds like a nightmare.
Managing this is like high-stakes air traffic control for the bedside nurses and pharmacists, trying to route all these life-saving, continuous drips into the patient's veins without causing a chemical pileup.
So if the logistics are this complex and labor-intensive, it makes patient selection critical. We can't always do this for everyone perfectly.
No, we really can't.
So based on the data, who are the specific subgroups of patients where we absolutely must prioritize the logistical hassle of the slow drip?
The data points very clearly to 3 vital clinical subgroups. The first group involves a phenomenon called augmented renal clearance, or ARC.
I found this entirely fascinating in the sources because this isn't about kidneys failing, which is what we usually worry about in the ICU. This is a hidden hyperfunction.
It's incredibly deceptive. When some patients suffer severe trauma, burns, or acute severe illness, especially younger patients, their bodies trigger a massive systemic inflammatory response.
Right.
That massive inflammation causes a huge spike in their cardiac output. Their heart starts pumping blood incredibly fast,
And all that extra blood flow rushes straight into the kidneys.
which turns the kidneys into hyperfilters. Up to 80% of ICU patients who have perfectly normal-looking serum creatinine lab results actually have these hyperfunctioning kidneys working in overdrive.
Wait, 80%?
Up to 80%, yeah. If a patient has an augmented renal clearance rate, say, filtering more than 130 milliliters per minute, they will flush a standard bolus dose of antibiotics out of their system before it even has time to work.
So the drug just washes right through them.
Right. One study showed that 55% of these ARC patients had completely insufficient antibiotic levels when given standard bolus dosing. For them, a prolonged infusion is the only physical way to keep up with their overdrive kidneys.
Wow. Okay, so if hyperactive kidneys are washing the drug out of group 1, what happens when the patient's own body isn't fighting back at all? Are there patients where the drug has to do 100% of the heavy lifting?
Yeah, and that brings us to the second priority group, the severely immunocompromised.
Right.
The sources highlight a major propensity-adjusted cohort study looking at severely immunocompromised patients with gram-negative bloodstream infections.
And just to clarify, propensity adjusted for a second, that essentially means the researchers used statistical math to perfectly match patients with similar baseline risk factors, right? So they were comparing apples to apples.
That's it, exactly. They wanted to isolate the effect of the IV strategy alone. And when they compared the apples to apples, the patients who received a loading dose followed by an extended or continuous infusion saw a massive 15% absolute reduction in their mortality risk compared to those getting standard short boluses.
A 15% drop in mortality just by changing the speed of the drip.
It's incredible.
Because their immune systems are offline, they rely entirely on the drug maintaining that perfect, constant, unbroken pressure on the bacteria.
The pharmacokinetics have to be flawless because there is no biological backup system.
Right.
And that transitions us to the final priority group, patients where the kidneys aren't working at all, but a machine is doing the filtering. Patients on continuous renal replacement therapy, or CRRT.
These are the continuous dialysis machines used in the ICU.
Right. Dialysis machines are incredibly efficient at pulling these drugs out of the blood, but the rate of clearance is wildly variable depending on the exact settings the doctor uses.
So it's hard to predict the drug levels.
Very hard. But studies show that utilizing continuous infusions in these patients achieves much more reliable, steady drug concentrations. Interestingly, it often allows clinicians to use lower total daily doses of the antibiotic while still successfully hitting the target MIC threshold.
So what does this all mean? Let's pull all these threads together. We've got the new strong recommendation in the 2026 guidelines, the 99% probability of saving lives from the Abdulaziz meta-analysis, the hidden ARC hyperkidney patients, the superbugs. What is the grand unifying takeaway for you listening right now?
I think the grand takeaway is that treating complex lethal infections like sepsis is no longer just about selecting the right weapon.
Right.
For decades, the dogma was identify the bug, pick the correct antibiotic off the shelf, and the job is done.
The chemical just does the work.
But that's simply not enough anymore. We are learning that saving a life is equally about mastering the exact tactical deployment of that weapon over time.
Beta-Lactam.
You have to outsmart the pathogen's defenses, and you have to outsmart the patient's own chaotic physiology. Prolonged infusion isn't just a different nursing workflow, it's a fundamental optimization of human biology.
We are getting vastly smarter about how we fight. But as with every major paradigm shift in medicine, solving one critical problem usually opens the door to an entirely new, lingering question.
It always does.
And the 2026 guidelines explicitly call out a massive unknown that I want to leave you with today.
Yeah, it's the question of antimicrobial resistance on a macro scale.
Right.
We have proven that prolonged infusions save human lives today during this specific ICU admission. But there is a theoretical evolutionary concern.
Which is?
Does exposing bacteria to a constant low-grade level of antibiotics rather than those sharp nuclear high-dose spikes actually accelerate their ability to mutate and develop resistance over the long run?
It's the evolutionary pressure cooker. If the steady heat doesn't completely obliterate every single microscopic bacteria, are we just slowly training the surviving ones to resist the heat entirely?
It's a profound question. Retrospective studies so far haven't shown any huge, terrifying spikes in resistance. The Bling-3 trial didn't find a statistically significant difference in patients acquiring multi-resistant bugs.
That's somewhat reassuring, at least.
It is, but honestly, no large randomized trial has been perfectly designed to answer this specific evolutionary question over a span of years. It remains one of the absolute most critical research priorities for the next decade of critical care.
It really brings this entire deep dive full circle. In a terrifying medical emergency, every human instinct screams at us to go fast, to use the blowtorch, to blast the infection.
Right.
The cutting edge of science has now definitively shown us that deliberately slowing down, sustaining the pressure, saves more lives right now. But we still don't fully comprehend what the long-term evolutionary cost of that slow, sustained pressure might be for the future of medicine.
It is a stark reminder that in critical care, we are constantly balancing the immediate, desperate survival of the patient right in front of us against the long-term evolutionary timeline of the pathogens we are fighting.
It's a fascinating, precarious balance. Thank you for joining us on this deep dive into the rapidly evolving tactics of sepsis management. Keep questioning the standard ways of doing things, because, as we've clearly seen today, sometimes the biggest breakthroughs in science come when we completely reverse our most basic instincts. Until next time.